Hey, what's up and welcome to the next live case demonstration in Power Up Endo's 90-Day Super GP. This is the first live case demonstration where I'm going to be showing you exactly how to treat upper molars. I know it's a big deal for you as GPs to make that leap into treating upper molars endodontically, but I'm going to show you step by step how to do it using the same Power Up Endo framework that we've been using as the guide and the roadmap throughout the entire course and through every single live case demonstration. All right, I'm going to discuss with you how I go about discovering whether or not an MB2 is present. In this case, there isn't, but I'm going to show you exactly how to do it so that in our next case, where there actually is an MB2, it's the same process and you'll find exactly how to discover it. So without further ado, let's get right into it. So this patient was referred for tooth number 2, which had a composite restoration that was placed 2 months prior, and the patient was complaining of significant pain to cold, as well as pain that has been waking him up at night while he's sleeping for the past couple of weeks. So the pain has generally been increasing since the restoration was placed. And when you look at the bite wing radiograph, you can see how deep that restoration really is in terms of its proximity to the pulp. And when we examine the periapical film, we can also appreciate that that MO composite is very, very deep. Also, I want you to appreciate that the pulp chamber appears to be open and we can make out some canals inside the roots. So we feel good that we're likely to have a very successful outcome for this patient. So just to summarize here, the diagnosis for this case is going to be, remember, lingering pain to cold, as well as pain to percussion this patient had. So the diagnosis is symptomatic irreversible pulpitis with symptomatic apical periodontitis. We have a favorable prognosis and clearly we're performing non-surgical root canal treatment. All right, so let's get started on this patient. We started initially with anesthesia delivery. Our patient is nice and numb, and now we're moving along. We're going to start by lowering the occlusion as we do on all teeth that have not had a crown. And we're using our chamfer burr just like we have done in all our cases. Alternatively, like I mentioned, you can use a football burr, but any of these burrs will do the trick, and it's just personal preference. It's just a quick little zip right off the top. And then we're going to go ahead and proceed with our access preparation with our size 4 surgical length round burr. And remember, when you're performing your access preparation on these upper molars, you're very rarely going to need to cross the oblique ridge. All right, so you want to stay within the confines of the oblique ridge, and you don't want to go too mesial either, because there's curvature on the mesial in the cervical area of the tooth towards the center. So if you go too mesial, you'll discover that you're actually going to pop out underneath what's in this case a composite restoration. So start generally in the area between the oblique ridge and a few millimeters from that marginal ridge as well. And as you know, the access preparation is going to be a rounded triangular form, and so you want to keep that in mind as you're creating your initial shape. And so we're making our way down. Notice it's some nice soft brushing motions, creating our general outline form of our access preparation. And in just a second here, we're actually going to drop right into the pulp chamber. So little by little, you will drop into the pulp chamber. Remember, we saw a nice open pulp chamber on our preoperative radiographs, so we're confident that we're going to have that little drop like we like to feel when we do our endodontic procedures. So there you go. We can already see that we're in the pulp chamber there. There's more refinement that needs to happen internally, but we know we're at least in the pulp chamber. We're going to just do some more refinement. Take your time, as always, with your access preparation, because it's going to make all the difference, and it's really going to set the tone for the entirety of the endodontic procedure. So I'm just slowly removing the dentin and unroofing the pulp chamber. And now we're reaching for our endozeber. Okay, so the endozeber, as you know, is non-end cutting. It only cuts at the side of the burr, and it's great for smoothing out the access preparation. A lot of these things I'm going to be repeating to you just so you hear it over and over again, and the repetition has a chance to settle in and really stick. So internally, we're going to start noticing a nice smoother outline form with our access preparation. There's going to be a little bleeding because we're dealing with vital pulp tissue. In this case, okay, you'll notice shortly that the palatal canal is actually very large. So we've got our Endo Explorer, and in looking for the canals, our patient felt some pain. So what we're doing is an intrapulpal here, just like we discussed earlier. So I've got Septicane loaded with a short needle that's bent 90 degrees, and I'm just flooding that pulp tissue with the Septicane in order to get a higher level of anesthesia. This patient had a negative cold verification after anesthesia, but even still had a little discomfort. And so don't be surprised if you have to perform intrapulpal anesthesia, fairly regularly. And now we're taking our ProTaper Gold SX rotary file, and we're going to be introducing it into the canals. I like to take care of the canals that are bleeding the most first, so we can get some of that pulp tissue out and be able to better visualize what's going on internally. In this case, that's the palatal canal. So I'm passing a lot of sodium hypochlorite inside the tooth here to try to get a lot of that pulp tissue dissolved away so we can continue to orient ourselves internally. So you can see that palatal canal at the top right edge of the access preparation now has far less pulp tissue, and it's bleeding a lot less generally within the entirety of the access prep. So our ProTaper Gold SX orifice opener is now being introduced into the distal buccal canal, and then eventually we'll introduce it right into our mesial buccal canal. But you can see this case was selected because it's a relatively straightforward case with some nice patent canals and an open chamber, and so these are the kinds of cases that are slam dunks. So we got the orifice opener right into the MB, and we can see the three main canals are all present. And the little tip that I'd like to pass along to you is, I generally instrument all my main canals initially before I even start the search for my MB2. And I do that for a lot of reasons. Number one, once you've instrumented the case, you can better visualize and triangulate the location of the MB2. And also, you're able to fully disinfect the canals, and you can leave sodium hypochlorite soaking in the main canals while you look for your MB2. This way there's more time for the sodium hypochlorite to do its disinfection action, right? So here we've progressed obviously to our working length determination and our glide path preparation. And I got my 10 file here. This is a 10C file, and it's being introduced into our MB. Our apex locator was put on, and we're finding that the working length for our mesiobuccal canal is 18 millimeters. So now we've taken that same 10 file and we've introduced it into the distal buccal canal, and we've got our apex locator clip on there, and we're determining in the distal buccal that our estimated working length is 19 millimeters, which is oftentimes the case. These roots are oftentimes symmetrical, and the distal buccal is usually a millimeter longer than the mesial buccal. Honestly, mostly due to the fact that the reference point is the mesial buccal, so it's a little further away from the reference point, but they're probably about the same length if you were to measure them, apples to apples. And now we're going ahead and taking our measurement in the palatal canal, and in this case, I'm going to be discovering that the palatal canal is huge. And so remember, when you're determining what your working length is with your electronic apex locator, you need the file to be snug. If you have a tiny file in a very large canal, your apex locator is going to be very inaccurate. And so you want to find a hand file that is going to be a snug fit in that canal to have a much more accurate reading with your electronic apex locator. So I'm going up, 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 up. I'm going to end up determining my working length with, I believe, a 30 hand file, which is, obviously much bigger than most canals where you determine your working length with. So even my 25 hand file in red here is still very loose, and it's causing my apex locator to jump quite a bit. And so we're going to keep going up until we have a tight fit. And there we go. There's our 30 hand file all the way down. I'm determining so far that the working length in the palatal is 18 millimeters. And there we have it. A nice snug hand file all the way down to the apex. And so we're going to use the 30 file eventually to take our working length in the palatal canal. But everything's starting to take shape. So now we're going to introduce all of our hand files, again, minimum size 15 in order to take our working length radiograph. These canals are already quite open, especially that palatal canal. And so, again, you can reach for the 15 files right away and seat them so that you can take your working length radiograph. So one by one, we're just loading this tooth. And here is that 30 file that's going to go into the palatal. I recommend when you're putting all your files, especially in upper molars, do the palatal canal last in terms of seating the file, because it's going to be the easiest because it's such a large canal. And so there we go. We have our working length radiograph here. We can see that the mesial buccal and the distal buccal lengths look great, but the palatal looks a little bit short still. So remember, our working length was found initially to be 18 millimeters. So we're going to increase that working length from here moving forward by 1 millimeter, and we're going to make that working length now 19 millimeters. And remember, that's going to be the same working length that we used in our DB. So our working lengths, our MB18, DB19, palatal now 19, okay? Everything else looks good. So now we're going to proceed into the instrumentation phase of the treatment. You can see that the steps are all the same. The roadmap is intact. The Power Up Endo framework is still going to be your guide throughout the procedure, regardless of the case complexity. So we're taking out our hand files, and we're going to start with our rotary instrumentation. So here we have our Vortex Blue 1504 rotary, and we're going to pass it through all of the main canals. First in our MB to 18 millimeters, then into our distal buccal at 19 millimeters. And I'm trying to give you a really centered view here, so that's obviously slowing me down a little bit. That's okay. And remember, just a few pecks. You don't want to go too aggressive. If it's not taking you to length, don't force it as usual. Let the file do the work. The technology on these files are outstanding, and they're going to do the work for you, unless you're not supposed to be progressing because there's some sort of obstruction, in which case you're going to go down to hand files. So that was our palatal canal, and now we're going to go ahead and irrigate with our sodium hypochlorite. Again, in just the 3 main canals for now. So that looks good, and we're just working our way up the ladder, just like we do in all our cases now. So we're going to go up to our 2004 Vortex Blue rotary file, first in the mesial buccal to 18 millimeters. That's great. You can see that visualization, once you got the rubber dam on and you have the bite block in the patient's mouth, is pretty good. You should be able to see, even though this is an upper second molar, the light required to do proper endodontic treatment is sufficient here, and we can see everything we need to see internally. That looks good. working our way up. Now we're going to get into utilizing the size 25 in just a second. Sodium hypochlorite throughout the case. Remember, volume is key, especially with these diluted disinfecting solutions. You want to pass at least 10, more likely and preferably 20 milliliters through the case. So here we go. We got our 2504 Vortex Blue all the way down to 18 millimeters. And then we're going to go to the distal buckle at 19, and then finally the palatal at 19. But this is, like I mentioned before, this is a little dance that you're doing with your assistant. Once you get to this point, you're kind of on autopilot, if you will, because most of the heavy lifting is already done at this point. And that palatal is easy. It's so large where you'll find that we're actually going to prepare to a larger size in the palatal than we do in the buccal canals. So we're passing, again, a lot of sodium hypochlorite through the case. Very good. And you can tell it's already taking shape here. This is kind of your textbook access preparation and your textbook canal locations. So here we have our 3004 Vortex Blue rotary file in the mesial buccal. Our assistant wipes. We take our RC prep and load it on the tip as usual, and then we go into our next canal, in this case the distal buccal, to 19 millimeters. And now into our palatal canal, again at 19 millimeters. A lot of sodium hypochlorite throughout the case. Remember, I didn't want to edit these down too much for you because I want to give you a realistic representation as to, how these cases go, and not make you think that these are, 5-minute molar endos, right? So now we are up to our 3504 Vortex Blue to 18 millimeters in the MB. And remember, on the outstroke, you want to do a slight brushing motion away from the furcation, right? A little further in the MB to get to length. There we go. We've reached length there. Wipe, load the file with RC prep, and then back. And now in our distal buccal to 19 millimeters. You'll notice here that there's no more stopper. The dental assistant will occasionally remove the stopper when he or she goes to wipe the file with the 2x2. Don't beat them up over it. You still have the lines present on the file that you can use to keep track of how deep you're preparing. And there's still a little bleeding in the palatal canal, even though we're this far into the instrumentation. That can happen because, remember, these large canals have a lot of pulp tissue inside. And the 35 is going to be our final rotary file that we're going to take in the buccal canal, both the mesial buccal and the distal buccal, but we're going to go up in the palatal. So this is a 4004 Vortex Blue. You need to have a snug fit in the apex, and that went down, and I felt a little resistance there. So the size 4004 is as high as we're going to go in the palatal. All right, so we have sodium hypochlorite, and now we're going to start searching for our MB2. Notice that we've got sodium hypochlorite really bathing the other canals while we search for the MB2. And so oftentimes in the area of where the MB2 is, you have a layer of dentin that's covering it. So you want to take either your endo-zebra or your chamfer diamond and kind of remove some of that dentin that's oftentimes covering where the MB2 is. And now under high magnification, we can see very clearly the floor of the pulp chamber. And remember, the floor of the pulp chamber has a map. You see those dark little lines that go from the canal orifice and kind of trace the map or the outline of where the canals are. And if you draw an imaginary line from the mesial buccal canal to the palatal canal, you use that as your guide. And then you look at where the distal buccal canal is, and you draw a line perpendicular to that MB to palatal line. That should be your approximate location of your MB2. It's going to actually be slightly more mesial to that intersecting line, but that's going to be the location of where you're going to be looking for your MB2. And we want to make sure that there's no dentin covering over the MB2, and so that's what we're going to be doing for the next few minutes of the procedure. So we're taking our Endo Explorer and we're poking nice and hard right into that area, trying to see if we can break into an MB2. So I like to use my ProTaper Bold SX orifice opener and just kind of peck in the area of where that MB2 is supposed to be. And it's a gentle peck because if it's blocked off, you can very easily break the tip of the orifice opener, which is not the end of the world because it's, it can very easily be removed unless it falls directly into one of the open canals. That's very unlikely. So I'm just pecking in the area, trying to see if my orifice opener wants to drop into an MB2 canal. So far, nothing. So I'm going to just remove some of the dentinal mud and continue my search. Now, when you use your high-speed round burr to penetrate down into where the MB2 should be, you don't really want to prepare in an apical fashion because you can perforate the case. So you're almost preparing laterally to continue to unroof any potential dentin bridge over where that MB2 should be. So it's very, very mild apical preparation, more lateral preparation or mesial preparation, right? So going back to my SX orifice opener and seeing if I can sneak it in, and we're not really getting anywhere. So we're starting to feel like there may not be an MB2 here. We're running into a solid stop. And this takes time. This is going to take you, you really should be looking for at least 10 to 15 minutes before you throw your hands up and say that there's no MB2. And remember, there's less MB2s in upper second molars than in upper first molars. So we're not thinking that there's definitely an MB2 in this case. But you really want to give it a chance here. Also, if you're dealing with a vital case, as we are in this situation, you'll likely find a little bleeding from the region of the MB2, which is great because that tells you that you do have an MB2 there that you need to continue to search for, assuming obviously you haven't perforated the case at this point. So I've got an 8 hand file and I'm trying to see if I can snake it into any MB2 crevices, and we're not getting anywhere. It's a solid block of dentin. So I'm trying again with another 8 file. This is a C file, and still we're not getting anywhere. It does not want to progress. There might be a little bit of dentin still over where the MB2 should be, where your orifice opener and your hand file might be trying to get into, but in this case, it's a solid block of dentin. So I'm going to just continue to unroof that area of where the MB2 should be, and we're going to just check one more time just to be sure. And clearly this is a little easier with a surgical operating microscope, but I do these same kinds of things with my loops. And I'm just pushing in there into that region of where the MB2 should be, just making sure it's not covered by a little sliver of dentin. And you can see that crevice there. I paused it here so you can see there's very little to no dentin covering the floor of the pulp chamber at this point, and we're starting to feel really confident that there's not an MB2 present. So we're just going to try one more time with our orifice opener, pecking in that area. And nothing. We're running into a solid block of dentin. And remember, this is a very gentle peck. This is not a hard push. The file shouldn't really bend a whole lot as you're doing this. You're just kind of poking in an area, because once that orifice opener touches a area where the canal is, it's going to get sucked up into that canal. So it's just kind of poking around and checking where you think it'll be. So a little more unroofing of that dentinal bridge, just to be sure. You don't want to do this forever because, you won't have anything left if you keep looking and looking and looking. And that's why this is really more of a lateral preparation when you're searching for the MB2 as opposed to an apical preparation. Because if you were just preparing apically at this point, you would have been deep into the furcation at this point, right? And there you have it. All right, so at this point we've given up that there's an MB2 and we're proceeding into our disinfection stage and going ahead and passing all our sodium hypochlorite through the case. Good, then we're aspirating out in the 3 main canals. And we're going ahead and proceeding to our 17% EDTA. Then we're aspirating out our EDTA, and then we're going to go ahead and move forward to utilizing our final rinse with our half-strength sodium hypochlorite. That's looking good. Remember, during that search for the MB2, the sodium hypochlorite had a chance to soak in the 3 main canals for a pretty significant amount of time. So, use that to your advantage. You're going to be using that time anyway to look for an MB2. You might as well let the sodium hypochlorite soak in the other canals just to increase your level of disinfection. And now we're aspirating out, and we're starting with our obturation phase of the treatment, which begins, as always, with drying out the canals with paper points. In this case, our Pro Taper F2 paper points. That's the red. In the distal buccal, and then finally in the palatal. And notice there's no more bleeding in that palatal canal. That tells us that we've got all that pulp tissue out. And now we're going to go ahead and introduce our sealer. Good. Remember, always with a passive seat of the tip. And now we're going to seat our gutta percha cones. Remember, we're typically going to be using gutta percha cones that are one size lower. So in the buccal canals, remember we finished with a size 35 rotary file, so we're using a size 30 gutta percha cone. However, in this case, knowing that the palatal canal is so large, we're going to actually use the same size gutta percha cone that we instrumented with. And I did that because, again, I know that the palatal canal is huge, and so there's a higher chance that we're going to overfill the palatal canal if we use a small gutta percha cone. So you can try with your smaller gutta percha cone, you're just more likely to overextend and start introducing potentially some sealer beyond the apex. You're going to know because your crimp is going to go beyond your reference point with a smaller gutta percha cone. So our size 40 goes all the way to length, and we're looking good. And now we have our cone fit, and we can see our cone fit looks great. Our cones are going right to the apex on all 3 of the roots, and we're looking good. We can see even in our palatal canal, even though we're using a gutta percha cone that's matching and is therefore potentially going to be a little bit too big with the thick bioceramic sealer, we even still have a little bit of a puff in the palatal root. So it's a good thing, and it's a reason why maybe you don't want to use small gutta percha cones or one size smaller in these big canals like our palatal roots of upper molars, or sometimes our distal roots of lower molars. And so now we're going to go ahead and sever off the gutta percha cones right at the orifice with our System B with the Buchanan Fine Medium 08 tip, and just burning them off right at the orifice level. Our buccals, and then now our palatal canal. But, you see the framework is always the same regardless of the case complexity. And we're just cleaning up the area, trying to be left with just the right amount of gutta percha. You don't want to give yourself so much excess gutta percha that you're compacting something that's 2 millimeters above the orifice level. So you want to sever right at the orifice level, or maybe even slightly above the orifice level, so you have a little extra to compact with. There you go. And now we're going to reach for our Buchanan pluggers. This is the size 1, the red plugger, and it's always the larger size of that red plugger. That's my go-to for most of my cases. So I'm compacting that down right to the orifice level in the mesiobuccal, and we're going to do the same for the other canals. But at this point, I'm just compacting, and then we're just going to be beautifying the inside. But you can see how straightforward this case can be when you can see what you're doing, when you know what to look for, when you have good anesthesia. In this case, you saw that we utilized an intrapulpal supplemental anesthetic technique, and you're systematic with the way that you do things. It's always the same. That's the goal. Just maybe slightly longer for certain steps when you have a complex case like an upper molar in this scenario. So a lot of water here just to remove the excess sealer, but you can see this is basically finished here. You want to have a nice clean area to work with. So we're just completing our obturation phase, and then we're going to proceed here in just a minute with the restorative phase of the treatment. And as usual, if it were me, I would go ahead and place a core buildup right here while the rubber dam was on, while the patient was already here. You're going to save the patient an extra return visit to your practice. You're going to save yourself a lot of chair time, and you're going to be ultra productive by being able to perform both your endo and your core buildup all at the same visit. Looking good, and take your time with this cleanup job. You don't want to rush this. You want to make sure that there's no excess sealer and gutta percha. And in the area where you prepared looking for the MB2, you're going to have a little gutta percha that wants to stick in that region. Don't kid yourself and make it look like you went ahead and found and filled an MB2. Just take away any excess gutta percha. There's really no need for that. So in this case, I'm actually using a paper point to try to flake off that gutta percha in the MB2 area. One of the reasons that that's so important is because if you think about it, if this case ever needs to be retreated and a provider sees gutta percha in the MB2 area, they're going to think that that goes all the way to an apex, and they're going to start prepping in that area and potentially perforating that. So, just fill what you've discovered. Don't kid yourself and start filling gutta percha where there was no canal found. Good. You want to have a nice, neat area to work with. And you can tell the stage has been set now for your core buildup, which is only going to take you an extra few minutes, right? And notice the access preparation is just large enough to have straight line access into the 3 canals, but is not crossing the oblique ridge and is not going too deep into the area of the mesial marginal ridge. So we placed our sterile sponge, and this situation I used Cavit as the temporary restoration. So I've put that in there, and now I'm using a moist pellet just to burnish that Cavit into place and hopefully get this temporary restoration to last until a definitive restoration is placed. But like I mentioned, go ahead, restore this case at this point. Your patient's going to do great. So the rubber dam was removed. Our post-op radiograph is taken. In this case, we took 2 post-operative radiographs because we had some overlapping in the first one. But we can see here we have nice root fillings all the way to the apices, nice compact root fillings as well, and just a neat case without too much struggling, without too much time involved. And this is exactly how I want you to treat these upper molar cases if you decide to treat upper molars. This is a very, very straightforward case that, again, I see all the time in my schedule that with the right training and confidence, you can handle and become a super GP. All right, there you have it. This was the first upper molar of 90-day super GP that we're going to treat endodontically. And in the next live case demonstration, we're going to have our upper first molar with an MB2, and we're going to do the same exact steps to try to discover the MB2, except in that case, well, there will actually be one. All right, I'll see you in the next lesson.